Sandra Ibrahim, and my drug which I'm going to discuss is ethionamide. This drug is indicated in the treatment of tuberculosis, and this drug is indicated when the patient is resistant to rifampin and isoniazid, which are the first choice in the tuberculosis. It is the second line drug for the TB treatment. It blocks the synthesis of the mycolic acid. TB can be urinary TB, pulmonary TB, ocular TB, CNS TB. So, when the patient is resistant to rifampin or isoniazid, then the second line of choice for us for the TB patient is ethionamide. Its side effect includes nausea, vomiting, diarrhea, abdominal pain, excessive salivation, anorexia, weight loss, psychotic disturbances, and hepatotoxicity. Okay, there are different variations in dose according to the age, and for example, in adults, 15 to 20 milligram per kg per day once daily. If patient exhibit poor GI tolerance, then in divided doses in maximum daily dose of 1 gram. Therapy should be initiated at a dose of 250 milligram daily with gradual titration to optimal doses as tolerated by the patient. A regimen for 250 milligram daily dose for 1 to 2 days, followed by 250 milligram twice daily for 1 to 2 days, with subsequent increase to 1 gram in 3 or 4 divided doses, has been reported. This scheme will be followed in adults, while in pediatric, 10 to 20 milligram per kg per oral daily in 2 to 3 divided doses given after meal, or 15 milligram per kg 24-hour as a single daily dose have been recommended. While in the renal compromised patient, the management is different. In end-stage renal disease on hemodialysis, 250 to 500 milligram per day CRL, creatinine clearance less than 30 ml per minute जिनका होगा for those 25 to 500 milligram per day, and those having the CRL greater than 30 ml per minute have no dose adjustment. Okay, this drug has different interactions with different drug. For example, it can increase the serum level of isoniazid, and there may be convulsions when administered with cycloserine. Excessive ethanol ingestion should be avoided because psychotic reaction has been reported, and there are risk of severe bleeding when ethionamide is combined with fluindimide. What is the drug toxicity? Due to the structural similarity of the metabolite to methyl isonicotinic acid to isoniazid, it has been suggested that toxicity is due to pyridoxine deficiency. Overdose of the drug causes serious neuropsychiatric symptoms and liver necrosis. Cases of severe hypersensitivity include Steve Johnson syndrome and DRESS, which can be accompanied by liver injury, have been described with ethionamide. Okay, there are different alternative brands. For example, Ethionamide, its manufacturer is Century Pharmaceuticals, and there are different prices of different brands. Ethionamide, and we have the Usemed. Okay, it is only available in single dosage form, that is in the tablet form, and the route is oral, and its strength is 250 milligram. Precator ethionamide tablet are supplied in bottles of 100 tablets as 250 milligram, orange film coated marked with W on one side and 4117 on reverse. Okay, it's irrational use. This antibiotic only treats bacterial infection. This should not be taken in viral infections such as common cold, flu, which is very in our country or in Pakistan. It is very common practice that although there is viral infection, but the antibiotics are also prescribed. So this drug should not be prescribed in viral infection. Using this antibiotic when not needed can cause it to not work for future infection, because if we if we are using this drug irrationally, so when the drug is actually needed, at that time this drug will not produce its effect. Continue to take this medication until full prescribed amount is finished, even if symptoms disappear. That is, the continuation of the drug should be there, and it is very necessary to complete the whole course of the drug. Stopping the medication too early or skipping doses may allow the bacteria to continue to grow, which may result in return of the infection and cause the infection to be more difficult to treat, that is resistant. The bacteria will become resistant. The irrational use of the first and the second line anti-TB drugs is spreading HIV infection. The major disadvantage, or we can say that irrational use of the drugs of the TB may cause HIV infection if we are not taking them properly. Okay, there is a case study regarding this drug. A 45-year-old foreign-born male of 60 kg with fever, cough, night sweats, fatigue, chills, and weight loss, whose CXR showed the cavitations in the right upper lobe. His sputum was collected and it gives positive AFB3 plus smear. The baseline labs were taken and the patient was started on isoniazid, rifampicin, ethambutol, and vitamin B6. As we have discussed earlier, that isoniazid and rifampicin are the first line drug and the first choice in the TB patient. Okay, what are its vital signs? Its sodium potassium is 35, 3.7, urea 22, and creatinine 0.9. Okay, how can be done assessment? Assessment can be done by sputum collection, performing the HIV test, and by AFB smear test. Okay, AFB smear test. This show if it positive. If the patient showing positive AFB smear, it shows that patient is strongly TB positive and it is infected. While taking the history, patient told that he was previously treated for TB but does not recall the regimen. Patient's previous history can impact its current treatment because he has one prediction for multi-drug resistant TB, which include his previous treatment for TB. With this information, the local health department send the sputum for rapid molecular DST, that is the drug susceptibility testing. After 3 days, the report shows resistant to isoniazid and rifampicin, which is the major sign of the multi-drug resistant TB. Now, as the patient becomes resistant to isoniazid and rifampicin, so we have to switch for another anti-TB drugs. And now, how we can manage it, or what is the plan? What will be the plan? As the patient is suffering from MDR-TB, so we have to develop the treatment regimen stepwise. There are different steps by which we can treat the multi-drug resistant TB. Okay, for the first step, first you will begin the treatment with any available first-line oral agent that include pyrazinamide, 1500 milligram, and ethambutol, 1000 milligram. But we should not use such agents which have high resistance. For example, first-line treatment. In first-line treatment, we have rifampicin and isoniazid. So in this case, we should not use isoniazid and rifampicin because patient has already become resistant to those drugs. So we can switch to other first-line oral agent that are pyrazinamide and ethambutol. Now, what will be the second step? Secondly, we can go for injectables such as kanamycin 750 milligram. Addition of the injectables depends on DST and treatment history. Okay, molecular DST is recommended for those individuals who have received treatment for the TB in the past. So we can give DST because as this patient has gone through the previous treatment of the TB, so we can recommend this patient DST, that is the drug susceptibility testing. Okay. Now this in step 3, after injectables, we will add fluoroquinolones, which include levofloxacin and ofloxacin. Use of fluoroquinolones also depends upon the treatment history and the DST, because if the patient has already become susceptible to fluoroquinolones, so this addition is also useless because patient has already become resistant to levofloxacin or ofloxacin or any fluoroquinolones. Okay, if any patient which is susceptible to ofloxacin, then we should switch towards more potent fluoroquinolones. Now, what will be the fourth step? The last choice for multi-drug resistant TB are the second line oral bacteriostatic agent, which include cycloserine and ethionamide. Both have the same dosage, that is dose, for example, 750 milligram. As we have discussed, that ethionamide will be the last or will be the second line oral choice for those patients which have become multi-drug resistant, because in the previous 3 steps we have given the first line oral agent, then we switch to injectables, then we switch to fluoroquinolones. Then in the end, when there are when the patient becomes susceptible to all these three steps, or the drugs which are given in those steps, then the last choice for us to give cycloserine and ethionamide. And this whole treatment should continue for 6 to 9 months with continuity. There should not be any skip in the dose. Okay, this is the reference. And, thank you.